Hello, hello. Am I audible? Hello, everyone. Thank you for joining. We're going to start the session very soon. I'm just waiting for everyone to join. I hope these sessions have been of use to you and whatever the tutorial notes that I'm sharing on the Telegram group, I think that might prove useful to you as well. We've already discussed so much, so many of the units in physiology, and today, आज हम basically start. I don't have that much slides, Aj. It's going to be a slightly shorter session as compared to the usual. Am I audible? Okay. We're going to wait for one more minute. उसके बाद हम start करते हैं. So आज के लिए we have about 80 slides today, and because that is due to the reason because when we are studying immunology, we left the complement वाला portion. तो आज हम वो भी cover करेंगे in case of blood. But obviously, topics like anemia won't be covered here because I think वो ज़्यादा medicine relevant topics हैं. And even if जो भी physiology में दिए होते हैं for anemia, that is very insufficient, I would say. And we should always study in an integrated fashion. So abhi we are going to go into the details of the RBC precursors and the iron transport and folic acid transport or vitamin B12 transport so that we can understand the pathological basis of anemia when we're going to study either pathology or when we're going to take up hematology in medicine. Okay, I think we should start right now. The rest of the people can join in as we speak. So today our topic of discussion is blood physiology. So let me just first tell you about the plasma, that is per se. So we know the plasma is mainly water by 92% of weight, and whatever जो भी remaining रह गया इसका plasma represents about 55% of the whole blood. ठीक है? And then we have the erythrocyte that contribute about 45%, and 1% or less than 1% we have the Buffy coat layer whenever we centrifuge the plasma or when we centrifuge the blood. So plasma के case में we have water that is 92% by weight. Then we have proteins, and what are the different proteins which are present in the plasma? We have either albumins or we can have globulins. We can have fibrinogen as well. Okay, and whatever is the other solutes, they're 1% by weight. And when we talk about the Buffy code, we are going to see about the leukocytes, neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Most of these immunological cells and their characteristics हमने immunology में पढ़ ली हैं. So today we are going to be basically going over platelets as well as your erythrocytes. ठीक है? Right. So what are the plasma proteins? Plasma proteins की अगर हम concentration देखें, it's about 7 to 10 gram percent, that is gram per 100 ml, that is gram per dl that we call it. उसमें से albumin characteristic composes to be about 50%, that's about 4 से लेके 4.5 gram percent, we take it as a normal albumin ratio. And then what we have the globulins. ठीक है? Then we have the globulins. Second that they're there, 2 to 2.5, that is a 2 to 2.5 gram per deciliter. And later on, then we have the fibrinogen, that's 0.2 से लेके 0.4 gram percent. Okay, we know all of them are synthesized by the liver except the gamma globulins, which are mainly synthesized by the plasma cells, that is your हमने जो पढ़ा था the B effector cells, है ना? And normally the albumin globulin ratio we have to remember, that's 1.7 से लेके 2:1, right? So this ratio can range obviously. Okay, So albumin का mainly role क्या है? Albumin we know because blood में we have something known as the Starling forces, और उसमें एक Starling force is our hydrostatic pressure and one is your oncotic pressure. So the plasma osmotic pressure that we call it, or we sometimes even call it as the oncotic pressure, ठीक है, that is characteristically pi c अगर हम लेते हैं, that's characteristically about 28 millimeters of mercury. So what does it do? It basically prevents water from going out and leaving the capillaries. Okay, it's like a protective mechanism against edema, I would say. So albumin contributes to that. What about the globulins? Globulins, different portions. We're going to study. We have already studied about the gamma globulins and the different types of immunoglobulins that we have. Okay, and we are going to study the alpha as well as the beta globulins. Then fibrinogen, we know it's going to participate in your blood coagulation, and then we have some regulatory proteins as well. All right. So what are the types of globulins do we have? We've already read the gamma globulins. So we have alpha globulin. Okay. So alpha globulin, alpha 1 globulin that I would say, usme se first example that you have to remember is alpha 1 antitrypsin, which goes without saying it should be an alpha 1 globulin. The second example is a thyroid binding globulin, which is going to transport the thyroid hormones in the blood, right? What about alpha 2 globulins? They're either haptoglobin, and we know in case of anemia, that is hemolytic anemias, haptoglobin is the one which is going to sequester the hemoglobin जो intravascular hemolysis से निकला है, ठीक है? So that is your haptoglobin. And what else? We have ceruloplasmin, which is going to transport your copper, ठीक है? Then what about the beta globulins? Beta globulins का एक example is your transferrin, okay? So that's your transferrin. We're going to move now on a bone marrow, and this is, I have a picture from Rubens, all right, Rubens pathology. So it's a very good picture of how the bone marrow architecture is laid down. So let's just study the some of the characteristic about the bone marrow. 50% cellularity of bone marrow, 50% is cells, 50% is fat. The myeloid to erythroid ratio in case of a bone marrow is myeloid progenitors are always more than the erythroid progenitors. So the ratio is 2 is to 5, 2 is to 5 ratio 1. Okay. So they're 2 to 5 times more than the erythroid ratio. Then if you look at one high power field, okay, we're going to observe 2 to 5 megakaryocytes, because if we example as this as one high power field, we can see there are 1 and there are 2 megakaryocytes in one high power field. What about the plasma cells? Plasma cells are going to contribute about less than 3% of all of the cells present, all of the cellularity, and your lymphocytes are going to contribute about 20%. ठीक है. One more thing that I want to physiology के basis पे, जब हम hematopoietic stem cell transplantation पढ़ते हैं, what do we want? हमें चाहिए कि जो donor है उसके सारे के सारे stem cells have to come from the bone marrow into the blood, ठीक है? But usually हमें ये पता है जो ये सारे के सारे precursors हैं, they are within the bone marrow due to a thing. What is that thing known as? It's known as a chemokine, ठीक है? So these are some substances जो कि bone marrow के अंदर present हैं और वो cells को अंदर की तरफ sequester करके रखता है so that it doesn't leave the bone marrow, ठीक है? In case of a hematopoietic stem cell transplantation, we need those cells to leave the bone marrow. Those case में just remember GCSF we use obviously. We use GCSF, जो भी इसके chemokine receptor present है over the stem cells, उसके कारण it comes out of the bone marrow into the blood and then we can harvest it. And same goes for a drug known as pletiaxofor. That is your it basically inhibits your CXCR4 receptor. What is that? It's a chemokine receptor. हमने already chemokines के बारे में पढ़ा है when we were studying cytokines in immunology. ठीक है? Just remember, whenever we talk about all of these growth factors or all of these cytokines जो भी हमने पढ़े हैं, which modulate the growth, just remember जो stem cells हैं, that is your pluripotent hematopoietic stem cells, they are not responsive to your cytokines. So it is always the precursor cells जो इसके बाद बनेंगे, जो progenitor cells बनेंगे, they are the ones which are either going to respond to erythropoietin or thrombopoietin or some interleukins. Okay? So that's a very important MCQ. Right. If you see bone marrow architecture में, you have these sinusoids. Okay, so these are the endothelial cells और यहाँ पे हमारे sinusoids हैं, ठीक है? So this is the sinus and these are your endothelial cells. उसके ऊपर से we have a layer known as the adventitial cells. Okay, so these dark blue color में जो है, these are your adventitial cells. Just remember जो megakaryocyte lineage है, that is always lying close to the sinusoids, as well as the erythroid lineage. So what is this? This is the erythroid island, and this is your megakaryocyte. ठीक है? They're always going to lie within close to the sinusoids. What about the neutrophils? As you can see, the neutrophils जो हैं, they are characteristically थोड़ा सा away from the bone marrow sinusoids. ठीक है? So that is architecture. And whenever we talk about this erythrocyte island, इसके composition क्या है? We have a macrophage in the center, which is known as a nurse cell. Okay. So what is it going to do? Macrophage जो है, it's going to have lots and lots of ferritin inside it. ठीक है? And via this transporter known as ferroportin, it's going to give this ferrous form of iron to the neighboring erythroblasts so that they can mature and form hemoglobin. Okay? So just remember the nerve cells present in the erythroid islands. Okay. Now this is again I've taken from Rubens only. So hemoglobin की basically we should know males के case में 14 to 18 gram per deciliter, females के case में 12 to 16 gram per deciliter, and same goes to hematocrit value as well, slightly more in case of males. Males के case में 40 to 54% and females के case में 35 to 47%. RBC count हमें we usually remember as 4.5 से लेके 6 million, ठीक है, per microliter. Reticulocyte count is 0.5 से लेके 2.5%, ठीक है, and this is the MCV that we take it as normal, that is 82 से लेके 100 micrometer cube is your mean cell volume. Then we have the mean corpuscular hemoglobin as well. Characteristic 27 से लेके 33 कई books में picogram. And your HC, that's your 32 से लेके 36%. Now leukocytes के case में we know it's 4 to 11,000. ठीक है, and differential count as you can see mainly they are the neutrophil granulocytes जो की हैं 50 to 60%. Okay, then that is followed by the lymphocytes very close 30 to 40%. Then you have the monocytes, basophils, and then basically we have the eosinophils. So basophils जो हैं they are the least amount of cells which are present inside the blood. Okay, and जो भी इनकी details है we already studied in immunology, so you can refer to that as well. Now, this is what I mean by the lineage. We know that there is a pluripotent hematopoietic stem cell which is CD34 positive. Don't forget that. इसके बाद अब ये क्या करेगा? It's going to divide into two. It's going to form a common myeloid progenitor or a common lymphoid progenitor. और आगे की जो भी चीजें हैं, that's a pre-B cell or a pro-B cell and the naive B cell. We have studied all of this portion in your immunology. Okay, so refer to that. अभी we're going to study about all of these things. ठीक है? So common myeloid progenitor. ठीक है? Now this common myeloid progenitor, what's it going to do? So let's just study erythropoiesis in detail now. So this common myeloid progenitor, as we see, it's going to form two further colony forming units. One is colony forming unit mix and one is colony forming units BME. Okay. So what does this BME stands for? Basophils, megakaryocytes and eosinophils. Okay. So it's like it's going to form a CFUB, which is going to form basophils. It's going to form a CFUMG, that's for megakaryocyte, and it's going to form a CFUE, that's Eden. And जो आगे के जो भी processes हैं, we're going to study this portion in detail. What about the CFU mix? जो भी रह गए हैं, that is your granulocyte precursors हो गए, or your monoblast precursors हो गए, or your eosinophils precursors हो गए. That is your CFU mix. So we have a CFU mix, we have a CFU BME, ठीक है? And all of these things we've already studied. So let's talk about erythropoiesis per se. पहला MCQ is कि जो pluripotent hematopoietic stem cell है, where do they come from? So my answer would be your yolk sac. If you have to be even more specific, we should always say that's an intraembryonic, aortic, gonado-mesonephros region. Okay, so these are two sites. Just see mesonephros region. Whatever is in the option, we can take that. Either it is from the yolk sac, or we can call it as the intraembryonic aorto gonado-mesonephros region. Okay, so how does it? Where do you start from? You know the yolk sac. So 2 से लेके 10 weeks it's in the yolk sac. Then yolk sacs they're going to migrate into the liver. So that is the hepatic stage of your erythropoiesis or your lymphopoiesis, whatever. Okay? So 10 to 24 weeks tak, they're now in the liver. That's hepatic phase. Now at 24 weeks, in some books it's 26 weeks, so be careful. 24 से लेके 26 is the range. तब से लेके birth तक जो भी हमारे myeloid जो भी हैं सारे के सारे, they're going to go into the skeleton. Okay? The lymphoid one are either going to remain in the bone marrow or they're going into your thymus. Okay? And after puberty, just remember it's mainly in the axial skeleton. ठीक है? जो मेरी axial skeleton की वो है, that's either your vertebra or your ribs, sternum, skull, pelvis, proximal end of femur and humerus. ठीक है? तो pendicular skeleton से now it has moved on to your axial skeleton. ठीक है? Just remember some form of embryonic hemoglobin that we have. So we have something known as GAWA1. Okay, so that is it has mu chains and it is a gamma chain. Okay, then we have GAWA2. Okay, उस case में it becomes alpha chains and it's an epsilon chain. Then we have Portland, that is your mu chain and your epsilon chain. Then obviously we have hemoglobin F, that is your alpha chains and your gamma chains. Okay, so just remember up to 8 weeks we are going to see embryonic hemoglobin, and after 8 weeks it's going to form HbF till 36 weeks. Okay, so adult values of HbA जो है that's going to reach anywhere between 6 months से लेके 1 year. And that is the reason why we are studying it in thalassemia. जो उसकी presentation है in case of thalassemia major, it usually occurs after 6 months, but because उस time पे we have HbF. ठीक है, so that's an important thing. So what are the marker for erythroid lineage? The एक अगर present होगा, then I'm going to say हाँ यार erythroid है, that's glycophorin. Okay, so you remember the CD markers as well. So glycophorin is the one. Okay, and whenever we talk about the myeloid lineage, just remember interleukin 3 and interleukin 6 is a very important growth factor for them. Okay, erythropoietin, thrombopoietin, that's going to be studied in megakaryocyte or your erythroid lineage, but mainly सबको influence करने के लिए it's mainly interleukin 3 and interleukin 6. Okay, and all of the myeloid lineage is also going to be positive for myeloperoxidase as well. ठीक है. एरिथ्रॉइड के लिए इट्स ग्लाइकोफोरिन एंड माइलोलिनियज के लिए इट इज माइलोपेरोक्सीडेज. ठीक है. राइट. So now we're going to study erythropoiesis per se. So what happened right now? We studied about the CFU-BME, that is basophils, megakaryocyte, and erythroblasts. Now it's going to form it. It's going to form a BFUE. Okay, so that's a burst forming unit erythroid. Okay, BFUE, burst forming unit. Burst was the organ in birds. जिस case में all of this erythropoiesis was occurring. ठीक है, तो burst forming unit. BFUE के बाद we are going to have the CFUE, that is a colony forming unit erythroid. Okay. Now इसके बाद जो भी हमारे वो हैं, we are going to study them in very much detail. We have first the proerythroblast, ठीक है. Then we are going to have the basophil erythroblast. Then we are going to have a polychromatophilic erythroblast. Then we are going to have an orthochromatophilic erythroblast. Then reticulocytes and erythrocytes. Okay. As we go down the line, what's going to happen? Let's see what are the changes. Then we're going to predict that. First, the size is going to decrease. First thing. Second thing, it's going to acquire more hemoglobin. If it's going to acquire more hemoglobin, it's going to become more eosinophilic. Okay. Then what else? It's going to lose its ribosomes. It's going to lose its nucleus. It's going to become less basophilic. Okay. So these are the things which are happening in this lineage. Okay. So let's just see एक को detail में. What are these cells? So this is what we are discussing: hematopoietic stem cells, CFU-GEM. Then we talk about the BFUE. Then we have the CFUE. अब हम बेसिकली डिस्कस करें कि वी हैव समथिंग नोन एज द प्रोएरिथ्रोब्लास्ट, बेसोफिलिक एरिथ्रोब्लास्ट. ठीक है. उसके बाद क्या आएगा? पॉलीक्रोमैटोफिलिक. पॉलीक्रोमैटोफिलिक का मतलब यही है कि इट इज बेसोफिलिक एज वेल एज ईसिनोफिलिक. व्हाट डिड आई गाइस? मैंने क्या बोला था कि बेसोफिल कम होगा एंड ईसिनोफिल विल बढ़ेगा. तो दिस इज वन इंटरमीडिएट स्टेज जिसमें दोनों आते हैं. तो दैट इज व्हाई वी कॉल इट एज पॉलीक्रोमैटोफिलिक. देन वी हैव द ऑर्थोक्रोमैटिक एरिथ्रोब्लास्ट, then the reticulocyte, and then obviously we have the erythrocyte. Okay, so just remember interleukin 3 and just remember interleukin 6, very important. ठीक है. erythropoietin कहाँ पे work करेगा? That is a very favorite MCQ which we are going to see in shortly. Okay, so what are the BFUE? All right, burst forming unit, first stage. So इनके cytoplasm में there are many polyribosomes. That is the reason why BFUE is very basophilic. ठीक है. As well as it's going to have the cytoplasmic extension जिसे हम pseudopods कहते हैं. And इसका अब न्यूक्लियाई अगर आप देखो, it's going to be fine chromatin and large nucleus. ठीक है. large nucleoli होंगे, well defined nucleoli होंगे, and जो chromatin है that is very finely dispersed. ठीक है, not granular. ठीक है. अब what do we have to see? अब हमने देखना है कि कौन से factors BFUE को stimulate करते हैं, कौन से inhibit कर सकते हैं. ठीक है. So let's see stimulant factors. What did I guys tell you? Myeloid lineage के लिए mainly interleukin 3 and 6 तो हमेशा रहेंगे. ठीक है. Then we have something known as the GM-CSF, that is the granulocyte macrophage CSF, colony stimulating factor. तो वो भी रहेगा. TPO as well as erythropoietin both can influence your BFUE. ठीक है. What about the inhibitory factors? Mainly we have transforming growth factor. ठीक है. We have TNF alpha and we have interferon gamma. So ये दोनों बहुत important है. Because whenever we are going to have any chronic inflammation, we know that is, for example, मान लो we have tuberculosis. ठीक है. So tuberculosis में we know it's a delayed hypersensitivity reaction. We have the formation of a granuloma वगैरह, activated macrophages वगैरह होते हैं. They're going to release some amount of interferon gamma. ठीक है. T helper cells release करते हैं interferon gamma, और we can have TNF alpha का release as well along with interleukin 1 and interleukin 6 जो भी हमारे active phase of inflammation को stimulate करते हैं. तो whenever inflammation is occurring, that's going to inhibit your CFUE, BFUE, right? So why is this relevant? Because we have something known as anemia of chronic disease जिसमें सब कुछ चीज होती है. However, you might be remembering anemia of chronic disease में there is something known as hepcidin also which plays a so sorry for the interruption guys. कोई problem हो गई थी इस करके. I think we were on BFUE only. ठीक है. Now we're going to start with CFUE. So sorry. So whenever we're going to talk about the colony forming unit E, that is erythroid. इस case में just remember it has a granular cytoplasm and इसमें बहुत सारे mitochondria present होंगे. There are many pinocytotic vesicles and it is very sensitive to erythropoietin. Okay. Now अब हमारे mainly proerythroblast पे. So let's just see over a proerythroblast and then we can discuss its characteristics. Obviously it has a very high nuclear cytoplasmic ratio. Nuclei बहुत बड़ा है and the chromatin, if we talk about, it's very fine granular chromatin. ठीक है. So there's going to be a fine granular chromatin over here. It has prominent nucleoli present as well. ठीक है. And cytoplasm अगर आप देखो, it's mainly a basophilic cytoplasm. And a very important MCQ here is, which is the state at which synthesis of hemoglobin starts? So this is the state जहाँ पे hemoglobin will start to form. Is it visible on a proerythroblast? No. ठीक है. As you can see, it's basophilic. So this case में it is forming. ठीक है. And we're going to discuss hemoglobin synthesis frequently. अभी देखते हैं. Proerythroblast हमने discuss कर लिया. Now let's move forward. We have a basophilic normoblast, okay, or a basophilic erythroblast. All right. So what is this basophilic? Isme what one thing I can see is the cytoplasm has become more basophilic. Okay, so it has coarse granular chromatin. As you can see now, fine granular nature, it's much more coarse. So it's a coarse granular chromatin, and very importantly, it has the maximum number of ribosomes. That is why it is the most basophilic of them all. Okay, and that is the reason why it's deeply basophilic cytoplasm. Now, next move forward, we have the polychromatophilic erythroblast. All right, polychromatophilic erythroblasm, as you can see here, I can see there is a fine blush of hemoglobin. Okay, so there is a fine blush of hemoglobin which is appearing as perinuclear eosinophilic staining. तो इसका मतलब ये है polychromatophilic erythroblasm में I can very much say कि hemoglobin has started to appear, right? मतलब वो दिखने लग गया in the cell. All right, so polychromatophilic erythroblast. Again, the size is decreasing to 11 to 15 microns here, and it has a small nucleus as compared to the other cells. And basophilic, and why am I calling it as polychromatophilic? It is basophilic due to the ribosomes, and it is eosinophilic due to the hemoglobin. All right. Then we have the orthochromatic normoblast. All right. Now again, what is happening here is now there is orthochromatic. Ortho matlab straight, right? So ortho ka matlab is karke, because now hemoglobin is the one which is predominating. So it is not going to stay in basophilic, and it's going to stay in eosinophilic. Okay. In this stage, the nucleus is starting to undergo degeneration. Okay. And what is the next stage? The next stage is the reticulocyte. As you can see, reticulocyte means there is no nucleus. Okay. It is larger than the RBC by 20%. Again, an MCQ. And what is going to happen is the reticulocyte initially has the mitochondria, it has the Golgi, it has the ribosomes. Okay. But first, the mitochondria is first to disappear. Then we're going to have the Golgi disappearing. And then ultimately, the ribosomes, they're taken care of by the spleen. And that is the reason why, in case of splenectomy, we get something known as Howell-Jody bodies, which are remnants of the ribosomes, which are not been cleared up from the reticulocytes. Okay, so we have already studied all of this. All of these stages we have seen. Now let's move forwards, and we're going to discuss something about erythropoietin. Okay, so the first important MCQ about erythropoietin is where it is synthesized from. So the first, the synthesis predominantly, that is 85% of your erythropoietin is synthesized from the type 1 interstitial cells in the peritubular capillaries near the inner cortex or the outer medulla. पूरा आपको statement याद रखना पड़ेगा, ठीक है? So it's a type 1 interstitial cell. They're mainly functioning like fibroblasts only, and where they're located, they're mainly located near the peritubular capillaries at the inner cortex or the outer medulla. What about the 15% remaining? That is mainly formed by the perivenous hepatocytes of the liver, and there are other sites as well. We can have the spleen, we can have the bone marrow, we can have the lung, we can have the testes, we can have the brain, many things. And this erythropoietin is actually not stored in form of granules or something. It's mainly synthesized as the need arises. Okay, so there is no storage, and very importantly, there is no feedback as well. Okay, so once it is released, it's not as if the erythropoietin is going to suppress the RBC the synthesis only in a negative feedback. So there is no feedback over here. Okay, so why is the erythropoietin increasing in the first place? Okay, we're going to see tissue hypoxia as the main reason. So how is tissue hypoxia being generated? Either you have an increase in the oxygen demand, or there is decreased blood flow to the kidney due to any reason, or there is a decrease in the hemoglobin concentration, or there is a decrease in the saturation, that is the oxygen saturation of hemoglobin. So whenever tissue hypoxia occurs and renal hypoxia occurs, so there is less O2. So whenever there is less oxygen, there is less activation of this enzyme known as lysyl hydroxylases. Okay, so it's an oxygen sensitive enzyme. It's activated by oxygen. So whenever this enzyme is not there, a substance which was being earlier cleaved by this enzyme, that is HIF1, that stands for hypoxia inducible factor 1. So this substance, ये जो substance है, it's not able to undergo degradation. ठीक है? तो ये क्या होगा? HIF जो है 1, that's going to increase now, and that's going to bind on the hypoxia responsive element on the 3' region of erythropoietin gene, और उसके कारण क्या होगा? Erythropoietin synthesis होगा. ठीक है? So that is how it's mediated. All right. A very important thing, between CFUE, मैंने क्या कहा था, जो BFUE है, that is not erythropoietin sensitive, that is erythropoietin independent, I would say. CFUE or proerythroblast के बीच में, it has the highest number of erythropoietin receptors. And when do the erythropoietin receptors decrease? That is, वो represent नहीं होंगे. That is at the level of the orthochromatic stage. Very important MCQs. ठीक है? If you remember, when we studied iron deficiency anemia, sometimes we study कि भाई उसमें platelet count is often increased. So why is that happening? Mainly erythropoietin receptors is not only present on the CFUE or the proerythroblast or something like that. It's also expressed on the platelets. And that is why we might have relative thrombocytosis in case of anemia. Okay? So it's all linked. So how does erythropoietin act, you might ask? As we studied cytokines की जब हमने family पढ़ी थी, तो we studied hematopoietin as one family. So it's like इसके receptor पे, that's known as a type 1 cytokine receptor. All right, so that is the main receptor that is for erythropoietin. And what kind of receptor it is? It is a Janus kinase receptor. Okay, a Janus kinase receptor, just like growth hormone and prolactin. Okay, type 1 cytokine receptor. So now we're going to study about the reticulocytes. As we know, reticulocytes lifespan is 1 to 2 days, and the concentration of a reticulocyte we already studied. That's 0.5 से लेके 2%. Okay, and a retic count is obviously a good index of your erythropoietic activity, और उसके basis पे we calculate something known as the reticulocyte production index in case of medicine. तो हम वहीं पे discuss करेंगे वो. ठीक है. So now we reticulocytes count हो गया, RBC precursors हो गए. अब हम RBC की बात करते हैं. It's 8 microns in diameter, we know. It's biconcave, हमें पता है, and it's non-nucleated, हमें ये भी पता है. ठीक है. So what are the stage of erythropoiesis? We've already studied कि कैसे वो hepatic stage में move करता है and ultimately into the bone marrow. And what is the origin of all of this? Pluripotent hematopoietic stem cells का, it's mainly from the yolk sac only. All right. And हमें पता है कि as soon as puberty arrives, we're going to have fat infiltration. Now it's only going to be mainly sequestered at only the axial skeleton or the long ends of your long bones, right? ठीक है. So this is the thing. So this is a diagrammatic representation कि कैसे हो रहा है ये. And now we're going to talk about the RBC structure thoda sa. All right. So this is the RBC structure. As you can see, we can have some different proteins here. You can have something known as the band anion exchanger. That's known as the band 3 protein. और band 3 protein के साथ there is something known as attached as ankyrin. ठीक है. और ये ankyrin band 3 protein को किससे attach कर रहा है? It is attaching to your alpha and beta chains of your spectrin. So you can have the alpha spectrin, you have the beta spectrin, and even ankyrin and इसके बीच में जो mediate करा रहा है interaction, that's also known as band 4.2. So just remember some of these proteins. You have band 3 here, you have ankyrin over here, you have the alpha and the beta chains of the spectrin over here, and ये band 4.2 है. This is also known as pallidin. And on the other hand, obviously you have glycophorin. तो यहाँ पे हमारा glycophorin है, यहाँ पे हमारा 4.1 है, and this 4.1 is attaching the glycophorin to your alpha and beta spectrin chains. Why is this so important? Because we have something known as hereditary spherocytosis, और इसका जो main जो form है 80% of the cases में autosomal dominant है, that is due to a mutation in ankyrin gene. ठीक है, ankyrin gene, which is on chromosome number 8. And all of these proteins are actually very responsible for what? It's responsible for the biconcave nature of this RBCs. और ये अगर biconcave है, then जो सारा hemoglobin है, that's going to collect at the ends of it. ठीक है, and we're going to have something known as the central pallor. ठीक है, so this is relevant उस हिसाब से. And just remember, all of these proteins, some of these जो सारे proteins होते हैं, they might be GPI proteins. What are these GPI proteins? मतलब they are glycophosphatidyl inositol linked proteins. मतलब GPI एक structure है which is going to link that protein into the membrane. And one of those GPI proteins हमारे anti-complement factors वाले protein है. That is your decay accelerating factor, जो हम अभी discuss करेंगे in case we are going to study paroxysmal nocturnal hemoglobinuria. Alright, that's a part of your complement discussion. Next, this we're going to discuss further on. Okay, that is your paroxysmal nocturnal hemoglobinuria and how is it mediated. Alright. So now we're going to move on your hemoglobin now. Okay. So hemoglobin is basically, it's a tertiary protein. Okay. It's a tertiary globular protein, I would say. So ये इसकी architecture की बात होगी. And how is it going to be formed? Let's discuss that. So पहले we're going to discuss something known as the heme chain. Okay. So this is a heme. Now this heme is going to combine with globulins. Okay. Alpha and beta globulins in case of your HbA1 जो है हमारा. But what is this heme composed of? It's composed of 4 pyrrole rings. So these are your pyrrole rings. And in the center, you're going to have a ferrous molecule. So that is your porphyrin rings. ये हमारी 4 porphyrin rings हैं. And in the center, you have this iron molecule associated with it. So this is the whole structure of the heme protein. All right. So so this is what we discussed about. ये जो pyrrole rings जो हैं basically, they're connected by these methylene bridges. All right. ये सारी हमारी methylene bridges हैं. And when the heme combines with the globulin, that is what we call as hemoglobin. And what is the structure? This is your heme. Alright, and one जो ये ferrous है, it's going to carry about oxygen 1. ठीक है, so अगर हम एक उसकी बात करें, एक heme की बात करें, that's going to carry 1 molecule of your oxygen. ठीक है, and this is the interaction that we are studying about at the pyrrole rings. ठीक है, alright. So now how is this synthesized? जो मेरे mainly all of this discussed in porphyrias, तो अभी हम basically दो enzymes के बारे में पढ़ेंगे. That is the initiation part, how is it synthesized, and the terminal part. So the initiation all occurs in the mitochondria. That is by succinyl-CoA, which is a part of your Krebs cycle. Succinyl-CoA is going to combine with your glycine, okay, with the help of the enzyme ALA synthase. Okay, that is amino-levulinic acid synthase, and it's going to form something known as delta amino-levulinic acid. Okay, so this is the rate limiting step, I would say. All right. So now this delta aminolevulinic acid is going to undergo many of these proteins, and you can refer to them. And accordingly, you have some deficiencies as well. For example, sideroblastic anemia is due to ALA synthase deficiency. Okay, as you can have different proteins being involved in all of these porphyrias. Okay, all right. So, Abhi, the types of hemoglobin that we have the major adult form, which we know alpha 2 and beta 2. So, there are two alpha chains, there are two beta chains. Okay? When we talk about the minor adult form, that's HbA2, which is 2 to 3% of your adult hemoglobin. That is your alpha and your delta chains. All right. And when we talk about HbF, that's your alpha and your gamma chains. Okay? Very important. ठीक है. And as we discussed कि जो हमारा basically 3 to 6 months की age पे the HbF is going to completely disappear. As you're seeing, this is the gamma chain fetal. Fetal hemoglobin is going to disappear at around 3 to 6 months age. So when we talk about oxygen transport in the blood, just remember that हमारा hemoglobin, if we take at 15 gram per deciliter as the mean, okay, so 1 gram per deciliter of your heme is going to carry about 1.34 ml of your oxygen. Okay, 1.34 ml. And how did we arrive at this 1.34? You might ask, is due to the Henry's law. Okay, so you can read all of this. Not due to so sorry everyone, I'm back right now. Okay, there was some problem in the streaming software. So now basically we are on iron transport abhi. So let's just see कि iron कैसे transport होता है and what happens. Okay, so now, so we know, so this is the diagram that I want you to see. So we can have dietary, mainly your ferric form of your iron. Okay, or we can have heme iron. जो heme iron है, जो heme iron है, that is mainly carried by your heme carrier protein. ठीक है, so whatever जो भी हम non veg वगैरह खाते हैं उसमें heme iron is a potential source of your iron. Whatever is your ferric form, okay, that is the thing that we have to take care about. So this ferric form is often converted by your vitamin C into your ferrous form, and that can be transported inside the mucosa. Okay, and how is it transported inside the mucosa, and how it happens is due to these transporters. So either we can have the heme can be transported by a heme carrier protein. Okay, whenever we have the ferric form, so some form of the ferric form can be converted to a ferrous form by your vitamin C. Okay, so vitamin C we know aids your iron absorption. But whatever is remaining, you have something known as the duodenal cytochrome B enzyme. Okay, that's going to convert your ferric form into your ferrous form. Okay, and now we have the ferrous form here. So we have a transporter in the enterocyte, that's a divalent metal transporter, DMT1. So it's going to transport your ferrous inside. Okay, now this ferrous is going to combine with your apoferritin and form ferritin, which is the storage cell. Okay, and at the basolateral membrane, what's going to happen is this ferrous form in the form of apoferritin might be released from the basolateral membrane of the enterocytes via a transporter which is known as ferroportin. Okay, very importantly, it's ferroportin. Okay, and once it is there in the ferrous form, now the transferrin जो है, that needs to bind to its where it's going to bind to a ferric form. So again, we need to convert your ferrous form into a ferric form. And how is it going to do that? By this enzyme, which is again present on the basolateral membrane. That's a hephaestin. Okay, it's a copper-dependent enzyme. Hephaestin. It's going to convert your ferrous form into your ferric form, and that's going to be transferred by your transferrin. Okay, it's going to be transported by your transferrin. And as we saw previously, एक हमारा एक enzyme है, एक हमारा एक protein है known as hepcidin. It's a positive acute phase reactant. Okay, so this positive acute phase reactant, that's hepcidin, is going to inhibit your ferroportin over here. Okay, it's going to inhibit your ferroportin over here. Okay, so this is what you have studied about the iron transport abhi tak. So this is what's happening. We remember the ferrous form being converted to the ferric form by this hephaestin. It's a copper-dependent enzyme, and this transferrin जो है, it's mainly delivered to most of the tissues. Okay, it may be many enzymes and cytochromes are iron-dependent, as you know. Oxidative phosphorylation में we have the iron-sulfur chains, which play a very important role. एंड जो कि रेस्ट ऑफ देम है, वी नो कि वी हैव द नर्व सेल विच इज इन द मैक्रोफेज, एंड वो मैक्रोफेज उसे बेसिकली एरिथ्रोब्लास्ट को सप्लाई करता है all of that the iron that is required for synthesis of hemoglobin, and that is your nerve cell via again the same transporter, that's your ferroportin. Okay, just remember, whenever there is an increased demand of iron from your erythroblast, whenever we are in iron deficient state, or whenever there is ineffective hematopoiesis and we need to increase the RBC cell turnover, so there is one hormone, I would say, that is released from the erythroblast, that's known as erythroferron. Okay, so this erythroferron is going to inhibit your hepcidin. So why am I concentrating on that is, whenever we discuss about something known as thalassemia, तो इस thalassemia में we have a process which is known as ineffective erythropoiesis. मतलब जो भी हम erythropoiesis कर रहे हैं, due to the alpha inclusion chains which are present in thalassemia, जो कि damage कर रही है RBC precursors को, ineffective erythropoiesis के कारण the erythroblast sense that we need more hemoglobin, and इसके कारण they release this erythroferron. And what happens is, the contradictory thing with what's going to happen is, this iron is going to prove not helpful to us, and that might lead to secondary hematochromatosis in case of your thalassemia. So उसमें जो hormone that is responsible is your erythroferron. Okay, so this is what's happening. And you should also remember the mucosal block theory that was given by Garnick, that states कि जितना हमें आयरन चाहिए होता है हम उससे एक्सेस कभी भी एब्जॉर्ब नहीं कर सकते. So whenever that access is there, that is shed off in the form of your erythrocytes only in the feces. Okay, so that is your mucosal block theory that we studied in biochemistry. All right, ठीक है जी. So all of this is done. Now we're going to talk about your B12 transport now. The B12 transport, again, it starts from the saliva only. So saliva has this salivary glands where they're going to release something known as haptocorin. So this haptocorin is going to bind with your B12. Okay, right. Now what's going to happen? Now it's going to enter into the stomach now. And what do we have in the stomach? Stomach, maybe we have the parietal cells. The parietal cells are going to release your intrinsic factor of Castle. But abhi it's not going to combine with your B12. Now it's going to go into the small intestine, where you have these pancreatic proteases, which we discussed, है ना? Trypsinogen, pro-carboxypolypeptidase, whatever, जो भी सारे proteases हैं, they're going to release that haptocorin, and now the B12 is going to be associated with your intrinsic factor. So where did this happen? In the duodenum. Okay, whenever the pancreatic duct opens into the duodenum, all of this stuff happens in the duodenum. And what next? Mainly हमारा B12 कहाँ से absorb होता है? Mainly it is absorbed from the ileum. Okay, and now we have the receptor on the ileum, that is CUBAM receptor, that stands for your cubilin amnionless receptor. ठीक है, तो ये जो पूरा जो हमारा कॉम्प्लेक्स है, ये पूरा का पूरा is endocytosed by the enterocyte and it's carried to the bloodstream and again to the liver. ठीक है, so this is your B12 transport. And what about your B9 transport? B9 transport ऐसे है because जो आप dietary folate जो आप consume करते हो, that is in the form of your polyglutamates. ठीक है, dietary folate polyglutamates हम उसे कहते हैं. And by the conversion of by this enzyme known as gamma glutamyl hydroxylase, okay, it's going to convert itself into monoglutamates, and that can be transported inside the enterocyte via this transporter, that is proton coupled folate transporter. So proton coupled folate transporter, and that's again going to go into the liver. Okay, so this is about that only. And just remember, folate is mainly stored in the liver and is enough for about 3 months. So whatever are the manifestation of folate deficiency, it will take some time to appear. Okay, and we know जो हमारा रोल है of folate is very important in case of your purine synthesis, है ना? जो हम DUMP into DTMP जो हम convert करते हैं via this 5,10 methylene THFA is mainly mediated by this thing only. Okay, and what basically facilitates that formation of your THFA in the free form is mainly B12. Okay, so basically what we study it as a folate trap. So let me just tell you about that. So this is what is the reaction is. So homocysteine it gets converted to methionine, and what will happen is this requires methylcobalamin. And how does the cobalamin receive this methyl group is from the folate. So this N5 methyl THFA gets converted to your THFA by giving this methyl. All right. So whatever मान लो the situation arises, we don't have any cobalamin. So we don't have any cobalamin, तो बात ही नहीं बनती है ना कि homocysteine will get converted to methionine. So if this cobalamin is not there, it's not going to accept the methyl group. So what we're going to have is N5 methyl THFA is going to increase, and at the cost of what? At the cost of your free THFA. So that is the reason why if we have to treat folate deficiency, we need B12. We need this methylcobalamin to convert the N5 methyl THFA into its free form, that is the THFA. And now when we have the THFA, तो क्या होगा? This serine molecule gets converted to your glycine through this enzyme known as the glycine cleavage complex. And what's it going to form? जो हमारा tetrahydrofolic acid है, that's going to form your N5N methylene THFA. And what's that going to catalyze? That's going to catalyze your formation of DUMP, say it's going to form DTMP. That's very important in case of your synthesis of your. Okay, so this is the thing which is happening. So उस case में whenever you're going to have impaired DNA synthesis in your megaloblastic anemia, we are going to have delay in cell division and time division will increase, and इसके कारण क्या होगा, the size is going to increase. मतलब what's happening is nuclear cytoplasmic asynchrony, मतलब nuclear maturation नहीं हो पाया है, so erythrocytes are not going to lose their nuclear anytime soon. And what's going to happen is जितनी ज़्यादा time nuclear अंदर रहेगा in the erythrocyte, it's going to form more around RNA, and that RNA is going to form more amount of your proteins. So what is that protein which we carry it as? Hemoglobin. So that is the main component of your erythrocytes. And that is the reason why whenever we have impaired DNA synthesis in all of these types of anemia, whether it is B12 or B9, we're going to have an increase in size. And what will happen if we increase the size? Obviously, it's going to undergo splenic sequestration and it gets damaged. Okay? So this is the pathophysiology of megaloblastic anemia. Okay? So now we're going to talk about hemoglobin per se, as we studied. Now we're going to study the degradation of your hemoglobin that occurs in the spleen. So this hemoglobin gets converted again, broken down into heme and your globin, and globin जो हमारा amino acid pool में चला जाएगा. This heme now is going to is going to break down again its iron form, जो कि iron stores की तरह चला जाएगा, and your porphyrin form. And this porphyrin is converted by this enzyme known as heme oxygenase into biliverdin. Okay? And this biliverdin is again reduced by your enzyme biliverdin reductase into your bilirubin. So biliverdin is green in color and bilirubin is your yellow in color, okay, which is responsible for your jaundice. So this is what happens, and this is the transport which actually happens in this case. So what's going to happen is now this bilirubin is going to bind with your albumin, okay? Bilirubin binds with your albumin, and that's how it's transported inside the blood. Now, very importantly, the first transporter of bilirubin, that is your unconjugated bilirubin, does not require any transport. Do you see? So basically जो पहला हमारा जो कैनालिकुलस है, जहाँ पे हमारा हेपाटोसाइट है, बेसिकली वहाँ पे इट डज नॉट रिक्वायर व्हाट, इट डज नॉट रिक्वायर एनी ट्रांसपोर्टर. सो ये जो बिलिरुबिन अंदर की तरफ आ गया है, दैट डजंट नीड एनी ट्रांसपोर्टर. तो अनकॉन्जुगेटेड बिलिरुबिन आ गया and it's going to getting converted into bilirubin glucuronide. That's a conjugated form of a bilirubin. ठीक है? अब इसका क्या हो सकता है? It is secreted into the bile canalicus. ठीक है? It's going to secrete it into the bile canalicus with this transporter known as MRP2. Right? What next thing paradoxically is going to happen? ये जो bilirubin glucuronide है, that is again excreted. Okay, it's again transported outside into the sinusoids via again this transporter which is known as your MRP3. So why am I emphasizing all of this? So if you see, जो पहला हमारा hepatocyte है and this is हमारा canalicus and this is हमारा sinusoid. तो यहाँ पे जो first unconjugated bilirubin, if you see, did not require any transporter and it's transported inside the hepatocyte without any delay. So this unconjugated bilirubin gets converted to bilirubin glucuronide. या तो वो secrete हो गया via this ABCC2 transporter, also known as MRP2 transporter, या फिर वो क्या हो जाएगा, back into the sinusoids it will go via this transporter known as ABCC3 or your MRP3. ठीक है? And this, what will happen again? It again gets reabsorbed. That is your conjugated bilirubin via this transporter known as OATP1B1 and 3. ठीक है? So organic anion transporter. So क्यों ये important है? Because when we studied about Dubin-Johnson and Rotor syndrome, तो हमें बहुत अच्छे से ये समझ में आता है कि Dubin-Johnson में why we're going to have conjugated bilirubinemia. क्यों? Hepatocyte में क्या था? Bilirubin conjugated था. And how is it getting excreted into the biliary canalicus? हमने बहुत easily कह दिया by the ABCC2 transporter, MRP2 transporter. So what's going to increase in the blood? Conjugated bilirubin. But we often fail to understand यार इस transporter के कारण, that is OATP1B1 and 3, which is going to transport your conjugated bilirubin, ऐसा हो कैसे पाया? ठीक है? So this is the reason what I'm saying कि unconjugated bilirubin को पहले it doesn't need any form of transporter to enter inside the hepatocyte. It gets conjugated. It is again excreted into the sinusoids. Then it is again reabsorbed via this transporter which is defective. OATP1B1 and 3. So that is the pathophysiology of a Rotor syndrome and Dubin-Johnson syndrome. So this we have studied. ठीक है? And now we're going to move forwards into your blood groups now. तो blood groups हमें पता है that जो हमारे H antigen mainly I would say is mainly by the chromosome 9 I would say कि सारे जो हमारे ABO blood types है they mainly dependent on your chromosome 9. And now we're going to discuss something known as the Lance-Steiners law. ठीक है? So Lance-Steiners law के accordingly it's stated whenever you have an antigen whenever an antigen is present on the RBC cell membrane, you're not going to have its corresponding antibody in the blood. That's the first law. And the second law was whenever you're going to have an antibody present inside the blood for an antigen present on the RBC, you're not going to see that antigen in the blood. That makes perfect sense. Okay? So that's known as your Lance-Steiners law. मतलब whenever we have type A type of blood group, that means उसके antigens present in erythrocytes पे. And what are we going to have? Are we going to have anti-A corresponding antibody? Obviously not. Okay? Does it have B type of antigen? No, it doesn't. So when this doesn't have the antigens, obviously the antibody will be anti-B antibodies. And the same can be applied over here. When we talk about type A and B, अब इस केस में क्या होगा? A एक antigen है, B एक antigen है, ठीक है? So whenever A and B both are there, मतलब whenever the जो हमारा allele है वो type AB type है, So it's co-dominant expression. Both of them will be expressed. तो दोनों के दोनों हमारे surface antigens आ जाएंगे A and B. ठीक है? अगर दोनों antigens present है, so neither anti-A nor anti-B antibodies are present. And what about O? O में, because O में it's only H antigen, it's not getting converted to either A or B. So H antigen, however, is present. So there is no A antigen, there is no B antigen. Are we going to see antibodies? Definitely we're going to see both anti-A and anti-B antibodies. And that's the reason why जो हमारा AB है, because it does not have any antibodies, we're going to use, it's going to be a recipient. And because जो हमारा type O है, it's not going to have any antigens, it's going to be a donor, universal donor. ठीक है? So that's about the blood groups. And just remember, जो भी ये blood grouping typing system है, we have already 36 different types. ठीक है? तो उसमें से the major ones which you study are RH and study at ABO. What others? We can have Kell, we can have Duffy, we can have Cade, we can have Lewis. ठीक है? We can have the MNS system, Lutheran system. There are multiple. ठीक है? We don't need to know. बस एक MCQ आया था कितने different systems हैं? We have 36 different systems. And Lansenius law we've already studied. However, there is an exception to Lansenius law. That is RH antigen के केस में क्या होगा? If we don't have the RH antigen, are we going to have RH antibodies naturally in our blood? No. We're not going to see natural antibodies until and unless we get exposed to RH positive blood. So that is the beauty. RH positive negative हो या ना हो, there's not going to be anti-RH in the blood. मतलब natural antibodies नहीं रहेंगी. You need to be exposed. ठीक है? And that is the whole issue with your RH incompatibility as well. ठीक है? So blood grouping we've already studied now. RH antigen ka gene, if you remember, RH antigen ka gene is in your IP1P. That is your short chromosome, short arm of your chromosome number 1. Okay? And what are the alleles do we have for your RH? We can have D, we can have D, small d. Okay? But actually the small d is a misnomer. There is no D gene. It's basically, we signify it as the absence of D. What other alleles do we have? We have capital E, we have small e. They can also be there, or we can have capital C and small c. But why do we all, हम हमेशा D के पीछे ही क्यों पड़े हैं? Because D is the most immunogenic. इसका presence और absence matter करेगा, और किसी का presence और absence matter नहीं करेगा. ठीक है? So that is the whole thing. And when does the RH antigen appear on the fetal RBCs? Mainly it appears on the day 38 of period of gestation. Okay? So this was I was talking about, because the D antigen is most immunogenic. That is why we say it either as capital D or small d. Just remember, there is no small d gene or any allele. It's mainly the absence of D that we signify. It's only D, or we can have capital C and small c, or we can have capital E and E. There is no small d. Okay? Very important. So we have discussed about the RH inheritance patterns as well. कि हमें ये पता होना चाहिए कि AB blood groups are dominant over O, हमें पता है ये बात. And जो AB blood groups, AB group genes together to themselves, they're co-dominant. ठीक है? All right. So RH alloimmunization हमें already पता है. Whenever there's a RH negative mother and we have RH positive fetus, पहली बारी क्या होगा? That RH positive, and we're going to see some form of fetal-maternal hemorrhage, which is most prominent during delivery. Some of the fetal RBCs are going to enter inside the mother. ठीक है? Did the mother have any natural antibodies against it? No. अभी हमने पढ़ा Lansenius law की एक exception है. But now it's going to develop some form of your anti-RH immunoglobulins. But initially they are IgM type. ठीक है? That's a primary immune response. But whenever again baby उससे हुआ, ठीक है? Whatever baby उससे हुआ, and again that is RH positive. Now what's going to happen is कि अगर because अभी antigens expose हो रहे हैं, now IgM is going to get converted into IgG, and we know IgG, except the IgG2, that is 3-1 or OB जो भी हैं, they're going to cross the placenta, and that's going to lead to erythroblastosis fetalis. ठीक है? तो ये हमारा alloimmunization का हमारा concept है. ठीक है? And what's again going to happen? So whenever हमारी antibody attach होने लग जाएंगे to the fetal RBCs, what's going to happen is it's going to lead to anemia, obviously. As soon as anemia occurs, now the placenta sees यार placenta को blood flow increase कराना पड़ेगा. So what's going to happen is blood flow, whenever it is increased, the fetus also undergoes polyuria. तो उसके कारण what's going to happen is, whenever you have anemia, we're going to have decreased blood flow to the kidneys. ठीक है? So there is decreased blood flow to the kidneys, and whenever we have decreased blood flow to the kidneys or decreased hemoglobin saturation in the fetus, it's going to synthesize your erythropoietin, kidney function, and then obviously placenta अगर increase करेगा, your placental sufficiency is going to increase, and then polyuria is going to happen, and polyhydramnios can occur. What else? Anemia, if it is undergoing, liver hypoxia में जा सकता है, and that can decrease your formation of your plasma protein, which is responsible for your plasma oncotic pressure, and that's going to lead to your edema and anasaka in the baby. As well as whenever there is anemia in the bone marrow, you're going to see extramedullary hematopoiesis either in the liver or in the spleen. This case में it's going to lead to hepatomegaly, right? And obviously जो हमारे hemoglobin अगर breakdown करेगा, it's going to form bilirubin. It's going to lead to jaundice and connectors, that is bilirubin induced neurological dysfunction in the baby. Alright. ठीक है, and we've discussed about chromosome 1 as well. Just remember, RH blood group in India, positive 85% of individuals are positive and negative is 15%. Okay, and it varies geographically as well. Okay, so just see the formation. Precursor हमारा H antigen है, and it depends upon which type of sugar residue is there on this antigen. Do we have A or B, or we have both? Okay, so whenever the enzyme that is present, which is going to attach your N-acetyl galactosamine to your H antigen, is going to form your A antigen. Okay, and whenever the enzyme that is there to attach your galactose to your H antigen is going to form your B antigen. Okay, and what is the Bombay blood group again? Bombay blood group में the problem is दोनों के दोनों नहीं है. Okay, so let's just discuss that as well. So H antigen, whenever A blood group कैसे होएगा? When there is a transferase type 1, this is going to act, this is going to attach your N-acetyl galactosamine. Okay, and whenever there is a transferase type 2, it's going to act to your attach your D-galactose. Okay, and whenever there's AB blood group, it's going to do both, and then you're going to have antigen A and B दोनों. And whenever we have O blood group, we don't have any transferase, but are we going to have H antigen? Definitely, we're going to see some H antigen, but that doesn't have any antigenic properties. Okay. What about the Bombay blood group? It's extremely rare, 0.0004%, and it basically is the absence of the H antigen, which is responsible for the A and B antigen. Okay? And what was the Lansing's law? Whenever you have the absence of that antigen, what are you going to have? You're going to form antibodies against it. Okay? So it's going to have anti-A antibodies, it's going to have anti-B antibodies, it's even going to have anti-H antibodies. So it cannot receive blood from any individual except its own. Okay? तो एक बॉम्बे ब्लड ग्रुप एंटीजन बॉम्बे ब्लड ग्रुप वाला पेशेंट कैन ओनली रिसीव ब्लड फ्रॉम अ बॉम्बे ब्लड ग्रुप वाला ही, बिकॉज उसमें क्या होगा, उस पेशेंट में द एंटीजन इज नॉट गोइंग टू बी देयर. ठीक है, वरना यू गोइंग टू हैव ए दोगे, उससे बी दोगे, कुछ भी दोगे, द एंटीजन इज ऑलवेज गोइंग टू बी देयर. एंड ऑब्वियसली दैट पेशेंट इन विच यू आर गिविंग हैज वेरी स्ट्रॉन्ग एंटीबॉडीज अगेंस्ट एंटी ए, एंटी बी एंड एंटी एच एज वेल. सो नीदर यू कैन गिव ओ, नीदर यू कैन गिव ए, बी, कुछ नहीं दे सकते. सिर्फ आप क्या दे सकते हो, एक ब्लड ग्रुप जिसमें खुद ही एच एंटीजन नहीं है. ठीक है, या ए एंटीजन नहीं है, बी एंटीजन नहीं है. एंड व्हाट इज दैट ब्लड ग्रुप? इट्स बॉम्बे ब्लड ग्रुप. Okay, so whenever you cross match, we have two types of cross matching. We can have direct cross matching, we can have indirect cross matching. What is indirect cross matching? मतलब donor की RBCs को जो आप दे रहे हो, you're cross matching it with the recipient's plasma, whether it can receive it or not. And what is minor cross matching? Minor cross matching का उल्टा मतलब है कि whenever आप donor का plasma for any antibodies which are present, you're matching it with the recipient's RBCs. However, this is less important. I would say this is more important because जो भी आप PRBC जो भी आप ट्रांसफर वगैरह कर रहे हो, बेसिकली जो प्लाज्मा जो है दैट गेट्स सिग्निफिकेंटली डाइल्यूटेड. तो इवन इफ देयर आर एनी एंटीबॉडीज दैट वाज प्रेजेंट इन द डोनर पर्सन, वो स्टिल वोंट बी एबल टू रिएक्ट विद योर रेसिपिएंट आरबीसीज और व्हाटएवर. ठीक है, सो दैट इज द मेन थिंग अबाउट योर क्रॉस मैचिंग. ठीक है, सो नाउ वी हैव सम ट्रांसफ्यूजन रिएक्शंस. हमें पता है वी कैन हैव इम्यूनोलॉजिकल एक्यूट ट्रांसफ्यूजन रिएक्शंस. उसमें से फर्स्ट हमारा इज एक्यूट हीमोलिटिक ट्रांसफ्यूजन रिएक्शन, व्हिच इज नथिंग बट योर एबीओ इनकम्पैटिबिलिटी. सो दैट इज वन. ठीक है, the second transfusion reaction we can have is your febrile non-hemolytic transfusion reaction. ठीक है, और इस केस में क्या हो रहा है, there is an increase in the body temperature. And why is it happening? क्योंकि जो recipient के anti-HLA हैं, that's going to react with their antigens transfused on the donor leukocytes and the platelets. Alright, that's the thing. What about the third one? Third one are all your allergic and anaphylactic reactions. And what about the fourth one? The fourth one is transfusion associated lung injury, TRALI. ठीक है. Okay, so that's basically acute respiratory distress is going to occur in the patient within 6 hours. Okay, all right. Then we can have non-immunological acute transfusion reaction, जिसमें first हमारा is non-immune mediated hemolysis. Why can that happen? Either due to mechanical or chemical damage, or it can occur due to extreme temperature, or whenever it is bacterially contaminated, or you can have some intrinsic cell defect which is present in the recipient. What about transfusion associated cardiac overload? ठीक है, that's mainly a form of congestive cardiac failure. ठीक है, why is it happening in which patients? Obviously pre-existing heart disease वाले patients में, या फिर end-stage renal disease वाले patients में, whenever the patient have decreased amount of cardiac reserves, or you're performing any rapid or massive transfusion, उस case में this TACO can occur. That's transfusion associated cardiac overload. Then we can have transfusion associated hypertension, we can have transfusion associated sepsis. So these are the different transfusion reactions. We can have immunological acute transfusion reactions, we can have non-immunological acute transfusion reactions. और हमने वो सारे के सारे पढ़ लिए, whether it is the febrile or with febrile non-hemolytic, or we can have the acute hemolytic transfusion reaction, or we can have the different ones we've already studied. We've studied about TRALI, we've studied about TACO. And what is massive transfusion that we say? It's either equivalent to the patient's blood volume. That's the first criteria, or in less than 24 hours. Okay? Or a single transfusion more than 2500 ml continuously is the category I would say for massive blood transfusion. And this is a very important MCQ for a university examinations or even for a NEET PG, that what are the things which are associated with a massive blood transfusion? क्या होगा patient में? The patient is going to develop hypocalcemia due to the citrate which is going to chelate with the calcium. तो hypocalcemia होगा, hyperkalemia होगा, and acidosis हो सकता है. You can have dilational thrombocytopenia. You might have hypothermia. You might have citrate toxicity. You might have hyperammonemia. You might have infections, and obviously your transfusion reactions can all of them occur. ठीक है, तो ये हमने सारे के सारे हमने पढ़ लिए हैं, right? So hemolytic disease of newborn we've already studied. Mainly the risk mainly will be in the second pregnancy, right? The rest of the details you can study it in OBG. We're going to study OBG. Now we move on to your platelets. That's your concluding discussion. We've discussed about RBCs. We're not going to discover leukocytes. So immunology में cover होगे. So what about the platelets? Platelets first of all 2 to 4 microns, very small, and उनका जो normal count है that's 1.5 से लेके 4 lakh per microliters or mm cube. They do not have any cell organelles. ठीक है? And the site of destruction for the platelets is mainly in the spleen. The lifespan is about 8 to 12 days. Mean अगर हम लें तो it's about 10 days. ठीक है? And what is it responsible for? It's responsible for the TPO, which is going to be synthesized by the liver and the kidney. That's a thrombopoietin. But hello everyone, is it visible? Am I audible? Please respond. कुछ problems आ रही हैं stream में. I think I'm back right now. So sorry for the disturbance. Please, if someone can hear me, please respond. Is my voice, am I audible? If someone could respond, please. Am I audible? Let me just perform a mic check myself. Am I audible? All right, I'm audible. Okay. So let me just continue. We were discussing about the megakaryoblast, how it has a round nucleus. Then the promegakaryocyte, if you see, again it has a basophilic cytoplasm, but comparatively it is less basophilic now. But it has what? It has a what is this? Reniform shape. Okay, kidney shaped इसका nucleus है. What about the megakaryocyte? They're the largest cell in the bone marrow. Okay, and इसके borders irregular है. They're ruffled borders, I would say. Ruffled irregular borders हैं इनके. And that is the thing what happens in immune thrombocytopenia purpura, that's ITP. Whenever you carry out a bone marrow aspiration or bone marrow biopsy, उस case में क्या होगा? The megakaryocytes are going to characteristically lose their ruffling because the antibodies which are formed in your ITP, they're going to make it lose its ruffling. All right. And then ultimately we have the platelets. They have anucleated pale blue colored structures with purple granules. That's your platelets. And what are the different kinds of granules do we have in case of platelets? We can have your alpha granules or we can have your dense granules, known as delta granules. Okay, दो different kind है हमारे पास. Okay, so what are the alpha granules? Alpha granules mainly have BWF, that's a von Willebrand factor. It is fibrinogen. It has PDGF, that's a platelet derived growth factor in its constituents. What about the dense granules? Dense granules mainly has serotonin. It has ADP, it has ATP, it has calcium, and it has epinephrine. So these are the things. We have the dense granules, or we can have the alpha granules over here. Okay. So what about the receptors which are present on the platelets? Let me give you an overview. Whenever there is endothelial injury, this VWF, that is the von Willebrand factor, is exposed. Okay, and when this von Willebrand factor is exposed, the platelets might adhere to the VWF via a receptor which is known as GP1B. It's actually GP1B95 that we call it. It's a pura complex with with some of the coagulation factors as well. The GP1B95 हम उसे कहते हैं, ठीक है, right? तो इस केस में क्या होगा? तो and what in case of Bernard-Soulier syndrome, ठीक है, you're going to have decreased expression of your GP1B. What about next? The platelets are going to bind to each other through fibrinogen. And what are the receptor which are present for your fibrinogen? It's mainly GP2B3A. Okay, so these are the receptor GP2B3A. So GP1B was for your VWF, and your GP2B3A is for your fibrinogen. Okay, so that's going to thing. And what about collagen? Collagen ke liye the platelets have your GP6. Okay, so two syndromes which are associated with it. Whenever you have GP1B ka decreased expression, that's known as Bernard-Soulier syndrome. And whenever GP2B3A ka you have decreased expression, that's known as Glanzmann thrombocythemia. How do I remember it? Mainly, if you remember GP1B and 2B and 3A, just remember whatever comes first, that's a 1. Okay, and alphabetically, what comes first is mainly your B, right, in front of your G. So Bernard-Soulier is mainly due to 1B, and your Glanzmann thrombocythemia is due to your 2B3A. Okay, so hemostasis कैसे होता है? Pehle, we're going to have vasoconstriction, which is going to occur whenever there is injury. Vasoconstriction is going to occur. Now, what you're going to have is the formation of a temporary hemostatic plug. वो कैसे बनेगा? पहले the platelets are going to adhere to either the collagen or the BWF. ठीक है? Now what's going to happen is the platelets are undergoing activation. ठीक है? So जो granules में से ADP जो release हो रहा है, that's going to bind to your platelet membrane, and that's going to lead to activation of your platelets, and that's going to lead to release of your platelet granules. ठीक है? All right. And what will happen next? Utme se hamara ADP is a constituent, so ADP can further activate your platelets, as well as they're also going to synthesize thromboxane A2 in situ. Okay, and this thromboxane A2 is going to lead to further aggregation of your platelets. Okay, and ultimately you have the activation of your coagulation cascade, and then we're going to have a definitive hemostatic plug with the formation of either extrinsic system or intrinsic system ke through. We're going to form your convert your fibrinogen into fibrin. Okay, that's a formation of a definitive hemostatic plug. All right. So this is the stuff. Before we discuss about the hemostatic plug and before we discuss about the intrinsic system, it wouldn't hurt us to know something about your kallikreins and your bradykinin. So let me just tell you something. So high molecular weight kininogens, we have these substances which are converted into bradykinin. Okay, via what? They're converted by plasma kallikrein. Okay, and what is the thing which activates your plasma kallikrein? So we have pre-kallikrein, which gets converted to your plasma kallikrein via this factor known as 12A. That's a Hageman's factor, factor 12A. It's a coagulation factor में जो participate करता है. Once the plasma kallikrein is formed, it's going to convert your higher molecular weight kininogen into bradykinin. Make sense? And this conversion is inhibited by something known as C1 esterase inhibitors. Okay, C1NH कहते हैं हम इसे. And इसकी deficiency के कारण we get something known as hereditary angioedema, जिसके कारण क्या होगा? We're going to have too much formation of your plasma kallikrein, too much formation of bradykinin, and what's going to happen? You're going to have angioedema. That's in case of your hereditary angioedema. Okay. So why is this kallikrein so important or bradykinin so important? Because 12 intrinsic pathway when we're going to study, let me just bring you that. Yeah. So intrinsic pathway में, how is the intrinsic pathway different from the extrinsic pathway? Extrinsic का मतलब ये है कि whatever that is, however it is getting triggered. ठीक है? Extrinsic का मतलब ये है कि it is being supplied by something which was not present in the plasma itself. मतलब endothelial cells or something like that are releasing something which was not present in the blood itself. That is why this is the extrinsic pathway. And intrinsic का मतलब ये है whatever was in the blood, that is the one which is facilitating your coagulation cascade. So let's first discuss intrinsic pathway. So you're going to have surface contact. Okay, surface में you have this negatively charged proteins, and sometimes even whenever the platelets are getting activated, उनके जो phosphatidyl serine residues है, they're going to get expressed on your plasma membrane. So whatever be the case, you're going to have some negatively charged thing, and that's going to activate your intrinsic pathway and activate your factor 12. What next? We can have pre-kallikrein and we can have high molecular weight kininogens. So all of them are activating your Hageman's factor. That's your 12. Okay. So this 12 is going to further activate your 11 to 11A. Okay. And this 11A is going to activate your 9 to 9A. All right. And what about this 9? This 9 is going to form a complex with your 8. Okay. This complex is known as your 10A's complex and going to cleave your 10 into 10A. Okay. That is the thing. So this is known as the 10A's complex. Now 10A आगे बीच में center में. So 10A के बाद whatever is going to happen, that's the common pathway. What about your extrinsic pathway? Extrinsic pathway, there is this tissue injury, और tissue injury के कारण you have released something known as tissue factor. ठीक है? Factor 3 कहते हैं हम इसे. That's a thromboplastin. ठीक है? And what is this tissue factor doing? This tissue factor is actually activating your something known as stable factor, which is a factor number 7. ठीक है? So 7 plus 3, I would say. And what is that going to do? This complex is going to activate your factor 10 into 10A again. Okay? So how do we remember all of this? So it's better to, if we just remember some sort of a trick here. So the trick is, whenever you combine 3 plus 7, it makes 10. Okay? And on the other side, when you have to talk about the intrinsic pathway, you count down from 12. Whenever you count down from 12, 10 will not be there. So you skip the 10, then you reach about 9, okay? And then you reach about 8. And 7 to yahan pe already present hai, so you're not going to discuss anything about that. So it's like 12, 11, then you're going to have 9, then you're going to have 8, then you're going to have 10. And we know, हमने जब tenase complex के बारे में पढ़ा था कि 8 and 9 both are going to form a tenase complex, and that's going to convert your 10 into 10A. And what will happen next, once the 10 is getting converted to 10A, is going to activate what? What is the next in line? We have thrombin. So this prothrombin, okay, gets converted to your thrombin. And once a thrombin is going to be formed, thrombin is going to convert your fibrinogen into your fibrin. But however, they are your monomers, fibrin monomers. Okay. So all of this are happening over here. So let me just revise it for you. So 12 was getting activated to 12A by surface contact pre-calligrants or bradykinin, okay, or high molecular weight kininogens. So this 12 Huygens factor is going to catalyze what next? 11. 12 के बाद we have 11. 11 gets converted to 11A. What next? 11 के बाद you should have 10, but 10 is part of your common pathway. So we're going to skip 10. Now we're going to have 9. So 9 is going to get activated. Here is the 9. 9 is going to get activated into 9A. What next after 9? 9 के बाद we have 8. So 9A and 8. And how is 8 getting activated? I'm going to tell you about that. But just remember, 8 and 9 are going to form something like the tenase complex. And that's going to cleave your 10 into 10A. Okay. On the other hand, we have 3 plus 7 ka formation. That 7 is your stable factor. And 3 is your tissue factor. And what is that going to form? That's going to form your 10A. Okay. Activated 10A. That 10A actually, 10A combines with your factor 5. Alright. So this is the factor 5 that I'm talking about. Okay. This is known as labile factor. And it's going to cleave your thrombin into thrombin what? 2. So this is what we have. So you have 10, 5 and 2. Okay, so this is what I'm discussing. 5 into 2 is again 10. So it's easy to remember. So 10 and 5 ka jo complex hai, I'm going to call it as prothrombinase, and that's going to convert your thrombin into activated thrombin. अब यहाँ पे एक चीज है, there's something known as the amplification which occurs during coagulation pathway. What is that? जो हमारे thrombin है, it has a beautiful mechanism. How is it going to do? ये अपनी खुद ही की formation को increase करेगा. How does it do that? This thrombin is the one which is going to activate your factor 8, as we saw. Okay, so this 8 was getting activated to factor 8A. So what was preventing 8 activation? It was bound to your von Willebrand factor. It was not being released by the von Willebrand factor, but thrombin is going to save the day and activate your 8. Okay, and what is 8 going to do? We know what 8 is going to do. It's going to form the tenase complex and generate 10. And what was 10 doing? 10 was basically converting your prothrombinase, activating your prothrombinase, converting into thrombin. So thrombin is facilitating its own formation. One more mechanism how it does that, it's going to activate your factor 5 directly. So you can see 2 here. So 5 labile factor is being activated by thrombin itself. 8 is being activated by thrombin itself. And even in some cases, 11 is also being activated by thrombin itself. All right. So that is the main thing. Once the fibrinogen is getting converted to fibrin by thrombin, now this fibrin monomers are going to develop into fibrin polymers via factor 13. And that factor 13 is also stimulated by thrombin. So thrombin has a lot of stuff doing. So this is known as the amplification pathway. How the thrombin that's activating your factor 11, that's activating your factor 8, that's activating your factor 5, and 5 and 8 itself are forming factor 2 only, and that's the amplification pathway in your coagulation cascade. We have already discussed about Klansman thrombocythemia, that is GP2B3A ka deficiency. This is also known as CD41 and CD61, and we even discussed about a Bernard-Sollier syndrome, जिसमें GP1B95 का deficiency था, and we call it as CD42. Okay, CD42B. All right. And we have discussed all about the activation as well. We discussed about all of the amplification as well. Okay. So these are the different coagulation factors. You can give them a read. Okay. We've already discussed all of them. Now, what are the anti-fibrinolytic mechanisms जो हैं? मतलब जो anti-platelet mechanisms है वो क्या क्या है हमारे पास? We're going to rush थोड़ा सा. So first we have the smoothness of the endothelium. Endothelium is smooth. It's not being exposed by something. So that's going to contribute to anti-platelet. Now, the next thing is the glycocalyx layer, which is on the endothelium. So that is anti-aggregatory for the platelets as well. Then we have something known as thrombomodulin, which we're going to discuss. We have something known as heparin, which is going to form a complex with antithrombin 3. We're going to discuss that as well. And we have something known as the tissue plasminogen activator. Okay. So you might be wondering, thrombin jo hai, it is a procoagulant as well, and it's an anticoagulant as well. It only depends upon कि हमें जो वो clot है, basically we have to limit it to some place. ठीक है. और भी उसके आगे जो भी चीज है वो thrombin जो है it's going to function as a fibrinolytic. How is it going to do that? Thrombin is going to combine with your thrombomodulin. It's going to form a thrombin thrombomodulin complex, and it's going to activate your protein S and protein C. And this protein S and protein C are going to lead to inactivation of your 5 and 8. Factor number 5 and 8. Very important. Okay? So that is the stuff about thrombomodulin and thrombin. What about heparin? So this heparin and your antithrombin 3 complex is also going to function as a fibrinolytic as well. And your tissue plasminogen activator, what's it going to do? It's going to activate what? It's going to activate plasminogen into plasmin. And this plasmin is the one which is going to cleave your fibrinogen ki polymers into its degradation products. Okay? So that is the stuff which is happening. What about next? Sixth factor we have is PGI2. That's going to inhibit your platelet aggregation. That is prostacyclin. Then we have nitric oxide being released by the eNOS, that is endothelium nitric oxide synthase, which is present inside the endothelium. So it's going to release nitric oxide as well. And we have the ADPase, which is going to cleave the ADP, which was being released by the granules. Okay. So this is the mechanism that I want to show you. So this is what's happening. So we have the heparin-like molecule and antithrombin 3, and it's going to inhibit many enzymes. It's going to inhibit 9, 10, 11, 12, 13. Okay. What about the thrombin and thrombomodulin? It's going to inhibit mainly your your factor number 5 and 8 through protein C and protein S. Okay. And what about the tissue plasminogen activator expressed by neutrophil cells? It's going to convert your plasminogen into plasmin. Okay. So these are the things which I want you to see. Just remember, factor number 2, 7, 9, and 10 are those factors which actually need vitamin K. Okay. So what happens is vitamin K, whenever it's in the active form, okay, so there is inactive vitamin K oxidized, gets converted to vitamin K epoxy reductase enzyme ke through, gets converted to active vitamin K. And this active vitamin K plays a role in gamma carboxylation. Okay. It plays a role in gamma carboxylation of factors which 2, 7, 9, and 10. Why is this so important? Because we have warfarin, which is a coumarin derivative. It's going to inhibit this enzyme known as vitamin K epoxide reductase. Decreased formation of active vitamin K will lead to decreased gamma carboxylation of these factor number 2, 7, 9, and 10. Okay? As well as protein C and protein S. Don't forget that. Even antiplatelet mechanisms like your protein C and S are also for vitamin K dependent serine proteases. They also need vitamin K as well. Okay? Very important. All right. So we have discussed that. Now, last thing that I want you to discuss is something about the prothrombin time and the APTT. So when we discuss about the prothrombin time, okay? So how do we perform that? Agar hum ye pata lag jaye, we're going to see how is it going to function. So we take platelet poor plasma, okay? जिसमें क्या है सिर्फ और सिर्फ coagulation factors है, which we want to discuss, ठीक है? Platelet poor plasma हम लेते हैं, उसमें we add tissue factor from outside, ठीक है? So we are acting tissue factor. That is your factor number 3, ठीक है? So if you're going to activate your extrinsic pathway, so obviously this prothrombin time is going to serve as an indicator of your extrinsic pathway. We're adding factor 3 from outside. That's your thromboplastin. And what are we trying to do? We're going to combine this 3 with 7. So what are we ultimately testing? We're testing the extrinsic pathway and not touching the intrinsic pathway. Okay? So it's like 3 we're adding from outside, plus we have 7 which is present in the plasma only. And that's going to trigger your extrinsic pathway and your common pathway to jayega. So what is it going to signify your efficiency of your extrinsic clotting pathway as well as your common clotting pathway. The normal that we take is 11 to 16 seconds. Okay? That's your important thing. And that's we have discussed about this. What about the activated partial thromboplastin time? In this case, we're going to perform the experiment somewhat differently. In this case, we're going to add something known as kaolin. Okay? Kaolin is like something like clay something. So ये जो kaolin है is going to activate your factor 12 by your negative charge mechanism जो हमने already पढ़ा. ठीक है? इस case में what are we testing? We are testing the intrinsic pathway. How we're not testing the extrinsic pathway because इसमें हम tissue factor डालेंगे ही नहीं. We're not going to add the brain extract over here. ठीक है? So we're going to have kaolin, we're going to have cephalin, which is going to function as phospholipids. We're going to have calcium from outside as well. Okay? And what is it going to indicate? It's going to indicate the efficiency of an intrinsic pathway because इसमें आप कौन सा factor activate कर रहे हो? You're activating your factor number 12. Okay? Which is being activated. And then ultimately you're testing the intrinsic pathway as well as your common pathway. So if someone asks you prothrombin time is an indicator of extrinsic as well as common, and your APTT is your indicator of your intrinsic as well as common pathway. Then we have something known as the fibrinogen assay, जो हम cross technique के through करते हैं, and उसके through we can take the what is the measure of your fibrinogen present in the blood. Okay? Right. So we have discussed this. Bleeding time, however, bleeding time is mainly a test of your platelet function. Okay? Coagulation time, when we say it's a function of your coagulation cascade. Okay? Prothrombin time and activated APTT we have discussed. There are abnormalities of the extrinsic pathway for PT, and APTT is for your abnormalities of the intrinsic pathway. What are some example of abnormalities of the extrinsic pathway is vitamin K deficiency, because those case may not going to have 2, 7, 9, and 10. So if you're not going to have 7, what's going to have? You're not going to have 10, we're not going to have 2. So it's mainly the extrinsic as well as common that you're testing. In case of APTT, we're having hemophilia as an example. We know hemophilia A is for 8 deficiency, hemophilia B is 9 deficiency. So this case, 8 and 9 are participating in what? They're participating in the intrinsic pathway of coagulation. So in this case, APTT will be prolonged, but the PT will be more or less normal in those cases. Okay? You discuss this, you discuss hemophilia A, that's for 8, hemophilia B, that's for Christmas factor 9, and hemophilia C, not for 10, it's actually for 11. Okay? And vitamin K deficiency we've already studied, that's for 2, 7, 9, and 10. Right. So the last topic that we have is actually complement. So complement ke liye I want you to tell, because there are three pathways for complement activation. So there is the classical pathway. We're going to have the alternate pathway, and the mannose binding lectin pathway. So what is this classical pathway? It's an antibody dependent mechanism. So it's a part of your adaptive immune response, okay, and not an innate immune response, okay. So what are the complement fixing abilities when we're going to test? It's mainly IgM, which is the most one, okay. Why is it IgM being the one हमेशा जो कि regulate करे complement, that is your classical pathway को is because for activating complement we need at least we need some amount of sites which are going to be there, ठीक है. वो इस केस में IgG वगैरह के पास नहीं हो सकते, ठीक है. So that is the main mechanism why is it happening. So IgM is the most one because it has the maximum amount of FC sites which are present, that is 5. And then it's followed by IG3, 1 and 2 in the decreasing order. IgG4 does not fix complement. So 2 MCQ तो यही हो गए. IgG2 does not cross the placenta and IgG4 does not fix the complement. Okay? And for every complement pathway, we're going to have 3 crucial steps. So what is that? First is the formation of the C3 convertase. Okay? उसके बाद we're going to have the formation of the C5 convertase, and उसके बाद we're going to have the formation of something known as the membrane attack complex. So let's see what's going to happen. हमारे एंटीजन है, यहाँ पे हमारे एंटीबॉडी बाइंड हो गया है, and these are the FC receptors. What did I tell you? We need at least 2 FC sites. So IgM के केस में we have 5 FC sites, but IgG के केस में we only have 1 FC site. So we need at least 2 FC sites. तो या तो 2 immunoglobulin बाइंड करें तब जाके बात बनेगी. So obviously IgM is much more positive, much more active as a activator of your classical complement pathway. Whatever be the case, C1 is going to bind over here. Okay? So C1 की 3 units हैं. You have the Q, R and S. Okay? So these are the 3 units, and ultimately पहले Q activate होएगी, then it's going to activate R, and then it's going to activate S. So now what is next is going to happen. So this is the microbe, and this is the antigen which is present over here, and this is the immunoglobulin, and this is the C1 which you're going to talk. Okay? अब C1 क्या कराएगा? C1S especially is going to convert your C4 into C4A and C4B. Okay? And as a rule, I'm going to tell you something. Every complement, whenever you break down, you're going to break down into A and B components. And usually I'm going to say, usually क्या होता है, जो B component है, ठीक है, the A component है, that is usually bigger. ठीक है? So that is the main thing that I want you to remember. ठीक है? So C4 जो C4A है usually, that's going to be bigger than the C4B. But there is an exception, that is C2A जो है, that is bigger than the C2B. ठीक है? इस केस में what will be happening, C4 is going to activate itself and gets converted into C4A. ठीक है? C4A कहीं और चला गया because the smaller unit, it's an anaphylatoxin. ठीक है? It's going to recruit more neutrophils. The C4B is going to bind with the microbe itself. अब ये C4B यहाँ पे bind हो गया. Now what's going to happen is, the next thing that's going to happen is just C2 है, that's also gets that's going to cleave into C2A and C2B, but C2B is bigger, so that's not. Yeah, so let me just resume that. अभी हमने basically बात किया कि जो C1 है basically it activates your C4 into C4A and C4B, ठीक है, and the C4B is the one which we keep, ठीक है. Next what's going to happen is C2 is going to get activated to C2A and C2B, and what we're going to keep, we're going to keep the C2A because that's the bigger subunit, that was the exception. So what is on the membrane of that the microbe, there's going to be C4B and there's going to be C2A. And what is this complex known as? This complex is known as C3 convertase. Okay? And what's it going to do? It's going to convert your C3 into a bigger subunit, that is your C3B, and a smaller subunit, that is your C3A. What is the C3A going to do? The C3A and C4A जो दो पहले हमने generate किया था, they're anaphylatoxin. They're not going to play a role here. What about the C3B? Now the C4A, C4B, C2A and C3B, in तीनों के complex को we call it as the C5 convertase. So can I say that C3 convertase, whenever it is joined by the C3B, whatever be the C3 convertase be, it's going to get converted into C5 convertase. And what is the C5 convertase going to do? It's going to convert C5 into your C5A and C5B, and just like that, A subunit, because it's always smaller, C5A is again an anaphylatoxins. Okay? So except for C2B, C2B was the kinin that we were saying, and C2A was the active subunit which was bigger. So this was the exception. वरना और जो भी हैं, that is whether it is C3A, whether it is C5A, both of them are anaphylatoxins. They're not playing a role basic in the classical complement activation. So once we have the C5B, which is the bigger subunit, C5B आएगा. Now what's going to happen is C6 भी आ जाएगा, C7 भी आ जाएगा, C8 भी आ जाएगा, and next C9 के multiple units आएंगे. So they're like a poly C9 complex. And what's that going to do? All of these C9 subunits is going to form a pore. Okay, so it's a poly C9 complex, and it's going to form a pore, and that pore is known as a membrane attack complex. So this pura portion, that is C5B, 6, 7, 8, 9, is known as a membrane attack complex. So इससे होगा क्या? Once the pore is formed, the contents